So what we're going to talk about in the next 15 minutes is management decision from both germline and somatic testing. These are all the different options that are potentially able to be decided from screening all the way through advanced prostate cancer and clinical trials eligibility. So I like to sort of frame this because most of us are not working in this domain all the time, but I like to put this into three different buckets. There's genomic profiling, genomic tumor sequencing, and then there's inherited cancer risk testing. So genomic profiling is after you've made a diagnosis, things like Decipher, Polaris. What we're focusing now on is the genetic and genomic testing and the sequencing standpoint, as well as from the inherited germline testing standpoint. And again, Brian went over this a little bit. We have germline versus somatic. Germline is what you get from it comes down from your parents and grandparents. Somatic are, I call them the Wild West of the tumor. They can develop in any tumor without any association with an inherited tumor risk. So again, the background to prostate cancer, about 10 to 15% of prostate cancer are hereditary. These mutated genes do not cause cancer that we talk a lot about, BRCA1 or BRCA2, but they interact with the environment to actually cause prostate cancer. We still do not know, unless somebody here in the audience knows what causes prostate cancer. It's a combination of factors. So why do we do somatic and germline testing? Well, it's to screen patients, as Dr. Helfand talked about, not only for prostate cancer, for other high-risk cancers, and then also in the patient and their family members. The somatic testing really impacts more therapeutic options. Germline impacts therapeutic options, but somatic sometimes is a bigger driver of precision medicine. So this is really what's happened in the last 10 years. We've learned that germline mutations occur in about 12% of men with metastatic prostate cancer, and that was from Colin Pritchard's very famous paper. But as time has gone on, more and more and more, we learned that these HRR gene mutations are probably present in 20 to 25%. Now, these are the key genes. Again, Brian talked a little bit about this. Again, these when mutated, when we use this term BRCA1, BRCA2, we're not talking about the naturally occurring BRCA1 or BRCA2 gene. We are talking about the mutated form. And again, there's literally hundreds and hundreds and hundreds. And later in the part and lecture, I'll give you a little bit more framework how we've gone down this pathway of learning about these genes. At least historically, the HOXB13 is the true inherited familial gene, and we can talk about that a little bit later. But this whole issue of homologous recombination response repair really is the core of what we're talking about, not only for the development of prostate cancer, but also for the treatment of prostate cancer. So the HRR response pathway is the main DNA rescue pathway that prevents a normal cell from becoming malignant. It ensures that you have an accurate repair of any kind of break that may occur in the DNA. And it's very important to understand that a mutated BRCA gene or any of the other genes in the pathway that you can have, the ATM check or other genes, they result in homologous repair deficiency or an HRD cell, which has compromised DNA repair and has a higher chance of becoming tumorigenic. Again, a lot of this is very commonly familiar language to medical oncologists, not so much in our world of urology, but it's important that we begin to understand it from both the screening and the treatment standpoint. So testing now, going to germline mutations, the inherited. You can either get a pathogenic or lightly pathogenic mutation. And again, there's hundreds and hundreds of mutations. There is not one mutation. You can get a germline test that comes back that says benign or likely benign. But the 800-pound gorilla, and I think this is a challenge for urologists, is the VUSs, the variant of unknown significance. Sometimes they're malignant, sometimes they're not. Why do I say that's the problem for urologists? Once you order a genetic test and that test comes back with a VUS, as the ordering physician, you're obligated to repeatedly check the gene bank and see if a decision has been made if this is a malignant or a non-malignant gene alteration. That's why I'm a big believer in using genetic counselors. Very lucky at an NCI Cancer Center, we have a lot of genetic counselors that we can refer the patients to. So everybody's familiar with many of these common specific genetic germline testing panels from a lot of companies, Color, Invitae, Ambry, and many, but you can see most of them have similar numbers of homologous recombinant repair genes, but some of them have different ones. And again, as the years go on, as Brian showed you, some of the articles are starting to kind of codify this a little bit more. We still only have kind of the top 5 or 6 genes, but there may be other genes out there that we worry about. Somatic tumor DNA testing is really become a very important treatment paradigm, particularly for medical oncology. Tissue biopsy traditionally has been the way that has been done, but we have an increasing interest, as was mentioned by Edwin yesterday, in liquid biopsies. It's commonly used to identify actionable genes for clinical trials, and it's also being increasingly used for therapeutic approvals. That's not to say that the germline mutated genes cannot be used for this, but if you don't have a germline mutation, and you have a somatic mutation, you can go ahead and use the somatic mutation for the drug approval or for clinical trials eligibility. And again, if a germline mutation is noted in the tumor, if you hadn't done it beforehand, you should go back and do germline testing to make sure you're not dealing with an inherited mutated gene that's now causing chaos in the tumor itself. And again, many of you are familiar with this is the somatic test. This just happens to be one of the ones that you get back from Foundation. The typical somatic test looks at over 300 genes, also looks at tumor mutational burden and microsatellite instability, which again are important for getting approval for drugs to treat certain patients that we'll address in a minute. Cell-free DNA really has become a big thing. We don't do it too much in urology, but my medical oncology colleagues increasingly are looking at cell-free DNA as a way of avoiding an aggressive tumor biopsy of a a bone biopsy or a node biopsy in a patient. If you can get a CDX somatic testing out of a circulating cell-free DNA, that's very helpful. So I always like to show everybody this because way back in the last century, we did what I believe was the first liquid biopsy in prostate cancer. This was way back in 1992. We didn't know what we were doing, but a bunch of us got together to try to figure it out. This was all before the NIH gene sequencing was completed. But the bottom line is we don't know what we were looking at. It might have been exosomes, it might have been circulating tumor DNA, it might have been cell-free DNA, but the point is this is now matured, 30 years later to the point where we called it micrometastasis, but there's obviously circulating factors. And again, the good news is other investigators such as Dr. Wyatt up in Vancouver showed us that you can get matched tissue and liquid biopsies show a very high concordance. So you can show if there's a change in someone's clinical status. You don't necessarily need to go back and they have metastatic castrate-resistant prostate cancer, subject them to biopsy, you can get a liquid biopsy. So again, somatic mutation testing gives us actionable mutations, particularly the PARP inhibitors as have been reviewed, but also in mismatch repair genes and high tumor mutational burden. These patients, it's rare, but they're eligible for pembrolizumab if they have a mismatch repair, the Lynch sequence of genes, or if they have high tumor mutational burden. Brian nicely is really one of the pioneers in the modern polygenetic risk scoring systems, but these are things that can be used to help with PSA screening. I won't mention too much about that because he did a good coverage on that. So decision-making, prostate cancer, which genetic testing guidelines do you follow? They're all over the place. This is just a listing of different AUA, ASTRO, ESMO, American College of Genetics and Genomics. ASCO just came out recently with a flow chart about how you should approach the patient, all patients with newly diagnosed metastatic prostate cancer, and basically they break it down into germline testing, which goes more towards the family or looking for other tumors in the patient, or more towards the therapeutic side. What do NCCN guidelines talk about? Family history of prostate cancer. If you know somebody has a germline mutation that increases the risk for prostate cancer, that should fit into your screening plans for that particular patient. As was noted by Brian, they might be higher risk and you want to keep a closer eye on them. If someone is identified in the family with a hereditary risk and they have a positive genetic test, again, it's up to you to work on the risk management. How intensely do you follow that patient who has a family history of prostate cancer for screening, or do you just go ahead and screen them immediately? But again, the other panel there is genetic counseling for inherited risk. I believe the patient needs to make the informed consent, because you have to realize as someone that is not diagnosed with cancer who's younger and ends up with one of these pathogenic germline mutations, they could have some problems with a bunch of insurance products. For example, long-term disability may be a problem. They're not denied employment, they're not denied medical care, but they may not be able to get certain insurance products. That's why I feel very happy when the genetic counselor actually talks to them about doing this family known as cascade testing and advise them what are the good things and what are the bad things about finding out if you have the gene that your brother or your sister may have. So again, this is called cascade testing. You know, I look at this and I sort of shake my head. You got colon cancer, you got prostate cancer. Who should be screened? Who should get genetic testing that's not been diagnosed with cancer? Again, leave it up to the genetic counselors. Just a brief touch. Here's an example. If you have somebody who's, let's say, their mother, their aunt, their sister all have breast cancer, this person goes out and gets a BRCA2 test. Lo and behold, they're a carrier, they're a male. What do you do with them? Do you diagnose their cancer? Do you follow them? The problem is if you actually diagnose a cancer in that gentleman, they have a worse prognosis. So these men will die 10 years sooner if they have a BRCA2 mutation. Again, you open up a whole can of worms when you look at these genetic tests. This is the NCCN guidelines for a workup of newly diagnosed metastatic castration-resistant prostate cancer. The patient has to have somatic testing, and if he hasn't had that, needs to have genetic testing as well. So again, as Brian alluded to, genomic profiling guides treatment. It helps you with metastatic castration-resistant prostate cancer. The PARP enzymes interact with the BRCA1, BRCA2 mutated genes, and again, that's really the magic that we now have with a brand new type of treatment for advanced prostate cancer. This is the time sequence that everybody is familiar with, but if you look at the lower right-hand corner with genetic testing, rucaparib, olaparib plus abi, talazoparib, and enza, all those require genetic testing for the drug to be approved, and below that is pembrolizumab if you've got microsatellite instability or a high mutational burden. Again, precision medicine. This is not just treating everybody with a PARP inhibitor to see what happens that you might have done 10 years ago. Today, you have to be very precise with the data you get back. So if you have genomic profiling, you now have a way to treat the patients. The germline or somatic testing is positive for one of these BRCA1, BRCA2 or in that family genes. You have FDA-approved therapies that are targeted. Again, this is precision medicine in urology at the highest level. And everything today, the new approvals for the PARP inhibitors, as you know, now combine an androgen receptor pathway blocker. The MSH high and the tumor mutational burdens are very infrequent, but if you have a patient that does have them based on somatic testing, you can treat them with pembrolizumab and it will be approved. So the options based on genetic testing, if you have an HRR genetic testing, you can have monotherapy or combined therapy with PARP inhibitors. Again, microsatellite instability or high mutational burden based on the somatic testing. Again, you have treatment options for patients today. And this is just a list now that starts with all the monotherapies that we have, then getting down here to the combination therapies that combine an androgen receptor pathway blocker along with a PARP inhibitor. So the bottom line is we have different consensus summaries. There's germline testing for those with newly diagnosed prostate cancer, and you can go through the whole discussion with them, family history, breast cancer, ovarian cancer, All the Germline panel recommends are down and below. Most of them are pretty consistent. For somatic testing, for either newly diagnosed or someone progresses, if they haven't had somatic testing, you go ahead and basically every guideline said you must do somatic testing on patients with metastatic castrate-resistant prostate cancer. So where are we with this area? Germline testing varies widely, and in fact, if you look at community studies out there, one study showed that only 13% of patients with metastatic castrate-resistant prostate cancer had either germline or somatic testing. So the field of urology has to try to do a little bit more. And again, I'm a big believer in referring to genetic specialists about this. So when I get back to Philadelphia, I hope they'll put me up on the Jumbotron again. We'll see what happens. But Philly, the Eagles did a lot with prostate cancer awareness, and I was lucky to pop up on the Jumbotron. So we'll see if they'll put my effigy up there in the next season. So thank you all very much.